People's Health is different from other insurance providers, payers as we refer to them sometimes, in that the ownership, it's owned by providers, physicians, whose main interest is to make sure that their patients, our members, get the care they need to achieve the best outcomes they can for their health care. What they see in People's Health are members, many times with other healthcare insurance companies or payers. They have medical management programs for different chronic diseases, but most of the interaction or the communication with members is either letters that they get or a telephone conversation with someone that calls them and helps them through. That can be very beneficial, obviously, but we go one step further than that. We have nurses and social workers and nurse practitioners that actually visit people in their home, that'll sit across the kitchen table from a member, that will talk to their caregivers, that will make sure that they understand what their role is in getting the best outcome for their health. So I think those are the things that really create the biggest difference in the way that we implement the programs that we have. The motivation is that you see what needs to be done when you look at a healthcare law that's 2,000 pages, and you say, how in the world, if I put myself in the place of the physician provider, am I going to accomplish this? And how in the world, as an insurance payer, am I going to accomplish this? And it cannot be done unless we get together. For the first time in my career, I am seeing that insurance companies, physicians, and hospitals are sitting at the same table trying to figure out how to get this done. For all of my career, I've seen this pretty heated debate about who's getting the best end of the stick, if you will, in how we care for health care. And there hasn't been a lot of agreement on what role each of us play in this and if we're playing together. I think that that's happening now because it's gotten more complicated and there are less dollars to accomplish it with. And when you do that, then you start thinking about the patient and what they need and how do we get them the services they need. And I'm really pleased in this community of the alliances that are being formed to do that. And that's part of what drove the Centers for Healthcare Advancement. We said, in order to do this within the budget constraints that we have, we need to make sure that we're following best practices. And we need to have a delivery system that can accomplish those best practices. And then we need to measure it to see if it's working. And that's what the Center for Healthcare Advancement is about. It's about getting together with the academic institution and the community physicians and designing a best practice for each one of the chronic diseases. Then making sure that the insurance company and the providers, the physicians, can come together with a delivery system to make sure that we can deliver the health care that's needed for that best practice. And that then we reach out to those folks that are really good at collecting the right data, at measuring it and seeing if it works or doesn't, and how do we need to tweak this system to make it better. That's what that whole process is about. It was really forced by the budget constraints we have and the desire to get the outcomes better. When you look at the different folks at the table with this, LSU brings a very unique piece to the table. You could say we would sit with our own physicians and design plans. But LSU, as an academic center, is teaching the physicians that we're using today and the physicians of tomorrow. In doing that, they're trying and do keep up with the best practices in how to address different diseases and different protocols today. There's a lot of work that goes into that. There's no reason to duplicate that effort. If we bring a physician out from LSU and design a plan, as we have, for example, with chronic pulmonary disease with our COPD program, we reached out to Dr. Russell Klein, who has a fabulous reputation at LSU and in the community, has taught most of the pulmonologists in this community. And so we work with our physicians and Dr. Klein to design the program. And then we asked Dr. Klein to go visit all of the pulmonologists in our network and discuss the program with them and see if they would buy into this, if they thought it was a good thing to do, the appropriate way to approach this disease. What you get then is you have a neutral party, someone that's at the academic center who's not the payer and who is not the provider, but certainly has a wealth of information and experience to design a plan that gets the buy-in from the physicians in the community and the buy-in from the payer to say this makes sense to do. I think that the physicians then, if they need help in making sure that the care gets delivered that way, that's what the health plan is here to do. If we can bring more clinicians into it, nurse practitioners, nurses, social workers, to make sure that the patients understand and follow these programs and that we give them the help we need, then we can measure the results and see where we are. I think that's really what has been working. We've got several of these programs designed now, and thankfully they're working very well. We've gotten very good reception from the community, physicians, and from the members. They see the results. They're feeling better. The doctors, I see doctors that tell me, I hate to admit to this, Carol, but I was going to see a patient in my office the other day, and they're all in the exam rooms, and the chart or the name of the patient that's in the room is on the door, and I walk up and I say, oh, it's Mrs. Jones. And what am I going to do for her? She's got this chronic illness that can't be cured. She's not feeling well. She's barely just staying stable. And I just don't know what to say to her anymore. And I open the door, and Mrs. Jones looks better than she's ever looked in the last 10 years. And, that nurse that works for you brought her to see me, and she's, my goodness, she's all dressed up. She's got makeup on. She's not cured, but her quality of life has improved. And that's because of the teamwork. The reality is we have great doctors in our community. We have access to the same procedures, technology, pharmacology as you do everywhere in the country. But this is not Colorado, and people don't go hiking for a lifestyle. And so we have to take into account the lifestyle we have, which includes smoking more than we should, eating more than we should, not the right things, not doing enough exercise. And we have to be able to take that treatment plan and sit with patients and start out by designing a way to do that that's realistic for them and get it done. My own physician, my primary care physician, I tease her sometime because I say, each physician, if you notice, and you may notice and really not pay that much attention to it, but I tell the physicians, they all have props in their office. Now, you don't think about a doctor's office as having props. It's not theater. But they really do. If you go into a cardiologist office, he's got a heart there, so if you've got a problem, he can look at it and tell you, here's what's going on. If you go in an orthopedic doctor's office, he's got the skeleton sitting there, and he can tell you, here's the problem with your knee, or here's what's happening to your hip. But what's the prop when you go in your primary care office? When you go in my doctor's office, the prop is she's got a little box and it's filled with groceries. And so she teaches you how to read the labels on these cans to know how much sodium you're getting when you get something, or how much sugar there is in it, or what you have to do, or what you should be looking for when you go to the grocery store to buy something. and how that relates to the illness you have and what impact that can do with everything else you're doing. So I think that I like to think of us as the extra prop in the box that go out and help people to bridge that gap, to understand what their role is to get better. The Center for Healthcare Advancement knows that people's health is focused on Medicare. And for the most part, while we do have disabled that are eligible for Medicare, and so there's that segment of our population that is not 65 and older, the majority of our members are. And so the programs that they design have that in mind. They know what the barriers to care are for seniors. They know the complexities that there are in a senior population that may have 5 or 6 different, what's referred to as comorbidities, or several different diseases that are being treated at the same time. What happens in those cases, the risk involved, the age factor in compliance and other issues that there are. So I think that they understand that geriatric medicine is different than providing a treatment plan for a 20 or 30-year-old. And that's all incorporated into the design that they do.